transport you to quite a big river. I think after the Amazon, it's the second river in the world. This is one area where it's not as wide as it is in some places, but this is the River Congo, full of romantic, historical associations, and even I was born and brought up in a town called Gravesend in the UK. There's a book written by Joseph Conrad which is called The Heart of Darkness. It's about someone leaving from Gravesend and going to the interior of Congo. I hope I didn't go mad like the main person in that novel did, but I'm going to take you back to the Congo. Congo is a pretty big country, and you can see there where Kinshasa, the capital, I spent some time here latterly, but I spent 17 years up here in the rainforest in a small mission hospital. We used to call people the hole in the forest. This was the sort of the hospital, and you can see how close the forest is surrounding it. And some people thought the only way I wanted to be, I needed to see more than 200 meters in any one direction, so I built an airstrip. Actually, the real reason for building the airstrip was that one USAID team who I tried to get to come to set up a rural health program said, "Oh, you're too rural." Sorry, I had a problem with that, but anyway, it's what they meant was we were so rural, we were too inaccessible. And you can see how close the forest is to the hospital. So this is the context of what we were doing. So what was PIMA? Well, PIMA is a Baptist mission. Eventually it became a hospital functioning as a government district hospital. 2 physicians, non-specialist range of services. There's a nursing school and a very basic eye department we'll look at in a minute. Within the WHO health structure, there is the sort of the health district concept. Normally this is a population of around 100 to 150,000, and the health district is responsible for doing all the primary health care in that region. So in fact, being part of that hospital, I basically was responsible up to an area which the population was around 400,000 latterly until they divided the district up. But being part of a mission, but being also part of a government, it touches a little bit on what Reinhold was saying, gives you a lot of extra possibilities as you develop health care, and particularly eye care. It was also a hospital that suffered and continues to suffer following war. During the peak of the war, MSF were basically helping out with the hospital. And it was interesting that the rebels decided they might need health care, so they wouldn't destroy the hospital. An important thing when you come to looking at health care. People do value health care. But one of the problems with the MSF intervention was that everything was done free, and the hospital's financial system was completely upset because nurses need salaries and so on. And those financial difficulties have continued and continue to this day. What about the eye department? Well, very basic equipment, you know, basic slit lamp, and there's equipment to do lid surgery, cataract surgery, glaucoma surgery, and as a spectacle workshop, which is still sort of functioning, but it's a bit difficult because actually at the moment there is so little fuel that actually things like the ventilator to help with make the lens fit the lenses into the frames needs electricity, so that creates a little bit of a problem. The technician works mostly at night. What were we doing before the war in PIMU? Well, we did around 1,500 consultations at the hospital each year, and you can see the list there. I won't kind of go through all those, but we did a lot of outreach as well in the region. Now, the area that I worked in for outreach was about the size of England. Now, I'm English, and I know what that means. I guess you guys don't know much about England apart from a former colonial power. But it was a big area, and you know, we need to think about that. It's like being in one of your bigger states and being the only person doing any eye care in one of your bigger states, the only person. But in spite of that, with the war, we've had considerable problems, obviously, continuing to run the program, and that's also a problem. And when you start talking about cost recovery, we decided that we should start doing a little bit of cost recovery, and we asked for a donation by the patients of $1. And after about 2 months, we abandoned it because most patients couldn't afford $1, and they preferred to be blind, or at least they had no choice. They could not find $1 for the surgery. And if you imagine that's for eye care, you can imagine that's for the whole health care, that's for education, that's everything. I told you, blindness is a fatal disease. It's also a disease of poverty and adds to the whole poverty trap. Here, a little bit just the outreach, just to show where we went. These centers were mostly centers where there was reasonable population or there was a reasonable service where we could visit. You can see a few gaps, and that's often where there was virtually nothing going on or where very few people were living. And to do this outreach, we had to use Mission Aviation Fellowship because, as I said, this size here, this map represents almost the same surface area as one of your bigger states. But I'm going to touch a little bit on what Reinhold has just mentioned. We have to look at eye care in a different way. We cannot look at eye care just in the sense of we are there, we're expecting patients to come. We have to go out, we have to work with the population. It means sitting down with village chiefs. They made me a village chief in the end in Pimu, so that was easier because I could sit down with them. But it means that we have to use all the mechanisms we can to try and convince people to come and use the services. It is not automatic to come and use the services. So we did a few surveys. And first of all, using our nurses, we went to the village around Pimu where they only had, some of these figures, I couldn't find some of the records. It might be slightly wrong, but it was just over 1,000. It may have been 1,008, 1,009 people. And we only found one person blind from corneal scar and one child with a unilateral corneal scar following measles. That was kind of gratifying. At least we didn't have people living on our doorstep. When I was in the Central African Republic, and I've been there for several years, our community team found a blind patient living 200 yards from my house. And they asked this patient with bilateral cataracts, why had you not heard of the eye clinic? Oh yes, I'd heard of the eye clinic. Why didn't you go to the eye clinic? Well, I was blind. Oh? I was blind. Yeah, the eye clinic's for people with red eyes, and that I'm blind. You know, that connect was not made. That actually we can not only treat red eyes, but we can actually cure blindness. And you don't get that sort of message unless you're out in the community working with the community. So that's very important that we make this contact. It's also important to see how we're doing. We did a survey, and I trained 2 nurses to go out, and they stopped. This is now, I'm still sticking with the UK. This is the size of Wales. I know a lot of people here like Ireland, but Wales is also another country that has some relationship with the UK, sometimes not always as good as it should be. This is an area the size of Wales, and we sent these nurses to everywhere where we had a health centre, and the health centre nurses should know their populations, and they should know who are blind. What they found was 9 patients had cataracts, and most of the cataracts were the far end of this road. Now, this road means that they are over 100 miles from Pimu. So, you know, basically, patients who are blind, not many of them like walking 100 miles because there's no other transport. So you have to think about that. You know, how do you get, some patients did walk more than 100 miles, but that's what we're talking about here, walking 100 miles. And, you know, if you have a cataract, that's just probably not worth it. You're old. And as Reinhold said, you may well be just pushed away. Yeah? You're just, well, you're too old for that. But we also had to look at, Pimu is in the forest. That's not a big population. We have to extend the work a little bit. And, Pimu is a village. Lisala was the nearest big town. It was on the other side of the river. It was about 90 miles away, but you had to cross the Congo River to get there. We used to visit there as part of our outreach. But that was an obvious place to set up an eye clinic based on where the population are and how people can have access to the hospital, or the hospital can have access to the outside. And the community were very keen to help. I got some money, I got a prize with some money once, and so I put some money into building these, providing the sheets, providing the cement, but the community built this whole eye hospital. And the equipment was donated by CBM, and you can see here even a generator. We had to do absolutely everything because there was no electricity in the town. It may be a sub-regional center, but it didn't have electricity. So we had to sort of bring in everything to do that. And it was a great day, an inauguration. All sorts of people came to inaugurate the hospital, and the women did some fantastic acting, nothing to do with eye care, unfortunately, but never mind. It still made a great festivity. We have one national doctor who is a trained cataract surgeon. She was trained, in fact, with us in Kinshasa. Two specialized eye nurses also trained in Kinshasa, and one locally trained eye nurse. So there's a staff there that can actually run this hospital and do some outreach. Financial management is always a problem in these centers, and we've set up a committee that sort of works. But with the war and everything else, unfortunately at the moment, the cataracts are around 200 a year, and as with most places in Congo, we're still doing ECCE and IOL. I want to finish by being a little bit controversial, because there's a few things that I think it's worth us looking at as we look at what we can do in outreach. First of all, we all have a tendency to go where we want to go, and that might not be a population center. I put it very controversially, beware of the mission hospitals, but mission hospitals are often not in the most accessible places. They've been put there for other reasons. Pimu was put in Pimu, not in Lisala, because the government of the day didn't want a Protestant hospital next door to a Catholic hospital, so they shoved us over the other side of the river. There are historical reasons why this is the case, but what we need to be careful of, we don't just keep going back to the same place because of history or because of whatever. Is this a place where we should really be setting up our eye clinic? As we set up our outreach, if we're going to waste our time just screening patients, let's try and make sure we have a team that can work together. We need to get patients involved. We need to get the community involved. We doubled our cataract output in Kinshasa by working with community workers. We now have 2,000 volunteers in Kinshasa, 2,000, but it's a town of a city of 8 million people. We have 2,000 people who are identifying patients and referring patients. The patients will not come on their own. And then measure your impacts. Do a survey. It's very easy to look at who comes to you. But if you don't go out in the community, and it reflects again what Reinhold was just saying, you don't know what's going on out there in the community. And I define this as the difference between running an ophthalmology clinic and preventing blindness. You can run an ophthalmology clinic and sit in your clinic. If you want to prevent blindness, go out and see what's in the community and make sure that what you're doing is the best thing you can do for that community. A nice view of the River Congo, just near Pimu. If you want to see a beautiful view like that every day, go to the River Congo. But once you're in the forest, you don't see any of it.